Let's talk about the sleeve gastrectomy. Sleeve gastrectomy is the newest surgery that we've added to our armamentarium here. I'm really very pleased with it. We've been doing it a little over 2 years now. We've done probably about between 100 and 150 sleeves at this point. Very satisfied, haven't had a severe complication. So it's at this juncture, from my experience, coupled with the data that is out there on the sleeve, very encouraging. There is some good, now long-term, good 5-year data, and some even small patient populations, but decent 8 and 10-year follow-up data in some of the programs that have been doing the sleeve gastrectomy that long. Again, I don't want to get too caught up in the anatomy, make you into a surgeon, that kind of thing. The principles of the sleeve gastrectomy are really basic and simple. If you're interested in the history and most of those things, go to my website. We have a section there that I give you in excruciating detail, the history and background of the sleeve gastrectomy. Let me give you my history with the sleeve gastrectomy. When it first was starting to be used as a standalone primary procedure, because it was initially designed, thought of as the first stage of a planned, very complicated 2-stage surgery in super obese people, 400, 500, 600, 700 pound patients. So when it was first being offered as a standalone primary surgery, I fundamentally saw it as essentially the same in terms of principles of how it works as the lap band, as an adjustable ring, if you will. As time has gone by and more data has become available on some other aspects of the sleeve, it looks like it's going to be much more profound than just a purely restrictive surgery. What you do to make a sleeve gastrectomy is you essentially remove 90% of the stomach and leave a long tubular, if you will, and that's where the whole notion of sleeve, like a shirt sleeve, tubular stomach of a fairly narrow diameter. But you're leaving all the basic functions of the stomach intact. The acid production to a small degree, the mulching aspect, converting the food from big chunks into smaller chunks, some hormones that the stomach produces, those kinds of things. But that long, narrow diameter, if you will, tubular stomach is very restrictive. The typical sleeve patient early after their surgery has about a 3-4 ounce, sometimes as small as 2 ounce portion size. A year out from the surgery, I think that the average, at least in my experience and what's reported in the literature, is about 3 to 5 ounces. Some folks a little bit larger, and again, some folks a little bit smaller. To me, the most important thing about that is not so much the portion size, but how many calories people eat over the course of a day. Typical sleeve patient of mine a year out from their surgery is eating about 900 to 1,000 calories a day. And early after their surgery are eating as little as 300 or 400 calories a day, a lot like early after gastric bypass in terms of calorie counts. And like I say, when sleeve gastrectomy first came out, that's sort of how I thought about it. The new information about the sleeve is all about this hormone ghrelin, G-H-R-E-L-I-N. It was discovered about 12 years ago by some Japanese scientists. It's actually, the name is an acronym. It's short for gastric hormone releasing. I'd have to look it up again to tell you what the acronym actually represents. But ghrelin is the only chemical that has so far been discovered that the human body makes that stimulates appetite. And it turns out the data seems to indicate, following sleeve patients for multiple years, that the best judgment is that the only part of the human body that makes ghrelin is your stomach. And it appears the only part of the stomach is the upper portion, what's called the fundus, the upper fourth or upper third of your stomach. Well, we're removing 90+% of that, maybe even a little bit more. So what do you think happens to your ghrelin production after you have a sleeve gastrectomy? It goes way down. Some folks almost immeasurable. What therefore happens to your sense of appetite? Goes way down. So let's see. Little tiny portion sizes, 3-4 ounce portion sizes, and you aren't hungry all the time. That sounds too good to be true, doesn't it? Well, it's not, but if that were the whole story, everybody would be having a sleeve gastrectomy and we would have abandoned all the other surgeries. Again, it's a very potent adjunct, and I don't think there's any question that is what makes it a growing in popularity surgery. But that's fundamentally how the sleeve works. There may be some other aspects in terms of how quickly or slowly your stomach empties, things that are yet to be elucidated. But the thing back about when I talk about the ghrelin data is when ghrelin was first discovered, we started measuring it in gastric bypass patients and saw this profound suppression after gastric bypass. But because we're not removing stomach, we're just rerouting things, what happens in those patients seemingly multiple years after their surgery? Their ghrelin hormone production starts to come back, so their normal appetite starts to come back. There is some good 4 or 5 year data on ghrelin levels after sleeve gastrectomy that shows persistent suppression of the ghrelin. Again, it's not definitive, it's not far enough out, it's not a large enough population of folks to say absolutely, but it is very, very encouraging. And there is no question I have seen that in my patients. And it's not really appetite suppression, it's not loss of appetite. What these folks will experience, and they'll tell you if you talk to one, is my stomach growls. It gives me some kind of physical cue to let my unthinking brain know I'm hungry. So on an intellectual level, I know my stomach needs filling, and on that intellectual level, I know I'm going to put something in it, but what I put in it, don't really care, doesn't really matter. It's a change in the psychological, emotional relationship with food. Food becomes stuff. You literally eat to live, not live to eat. And again, most of my sleeve patients, when I bring this stuff up to think about, they're like, well, isn't that why I'm here? Yes, I understand for the overwhelming majority of y'all, but there are some folks who roll through here that little tiny portion sizes and not having a normal or a typical psychological, emotional relationship with food could be a deal breaker for them. For example, a patient of mine who trained at the American Culinary Institute, chef, owns his own restaurant, little tiny portion sizes, and not having that emotional response to food, he could lose his ability to make a living. Does that make sense? I think it does. So again, sleeve gastrectomy, excellent surgery, very powerful tool, looks like it's definitely not just going to stick, but maybe one of the most potent tools that we're going to have. And the additional thing about it is without question the most user-friendly weight loss surgery for the overwhelming majority of my sleeve patients that I have ever seen. Unlike the gastric bypass, there's no dumping syndrome. You're not doing real complicated surgery, rerouting a bunch of small intestine, that kind of stuff. So scar tissue, obstructions, that kind of thing. You just don't see much. The leak rate is very, very low. Haven't had one yet. Don't plan on having one, but it could happen. And the other thing, unlike a band, no need for adjustments. Pretty much it's you have it, recover from it, learn how to work with it, and that's basically it. But don't kid yourself, just like I keep beating this dead horse over and over. If that's all there was to your surgery, to your treatment was which surgery you had, we would be done after I operated on you. And it's not. It's all about your multidisciplinary program. There are sleeve patients who did well for years who are now having weight regain issues. As an aside, in my opinion, those are for technical reasons from the time of their surgery, but that's yet to be established yet. But don't believe that your sleeve is a cure-all. It is not. If you're not exercising, if you're not eating off the correct menu, if you're not following our dietary and behavioral instructions, it may work initially, but it won't last. And let me leave you with this last example of what I'm talking about. I said earlier, a typical sleeve patient eats those first 6-12 weeks after surgery as little as 300 or 400 calories a day. If you told me that for the next 12 weeks you were going to feed me 400 calories a day, I would tell you, don't stock up. I'm not going to live that long. I cannot sustain life for 3 months on 400 calories a day. Why? Because my metabolism won't change. You won't watch me starve to death. I'll go into heart failure because I'll start metabolizing my heart muscle to keep my protein levels up. But you will watch me die. I cannot sustain life on 400 calories a day. But my sleeve patients, they make it look like a miracle. Lose their fat, hang on to their muscle. How can that be? How does that work? It's because y'all's metabolisms not only slow a little bit, like I once thought, Y'all's metabolisms, when we calorie restrict you, can slow to as much as 400 or 500 calories a day. And you make 400 calories a day look like a diet miracle. You want to know how slow your metabolism gets? That's how slow. So at the end of the day, whether you're eating 400 calories, 800 calories, 1,200 calories, doesn't really matter. Your metabolism's going to throttle to match it. The key to long-term success is not so much what you're doing on the calories inside, how many calories you're consuming. Our surgery's going to take care of that. It's what you're doing on the calories outside to burn additional calories, to overcome your funky genetics, your funky metabolism. So again, sleeve, great surgery. There is no question. I am a big proponent of it now. It's not for everybody, but don't kid yourself. It's just a component of the multidisciplinary program. And then the last thing, and it's sort of the conversation that I have on the lap band video if you've watched that, I tend to find there's just a personality profile that goes along with being comfortable with the sleeve. And it's sort of a zero maintenance, a set it and forget it kind of mentality, and a very high tolerance for making irreversible decisions. And when you think about the sleeve in terms of its irreversibility, when we cut 90% of your stomach out and throw it in the trash, we're not going back and getting that somewhere down the line. But don't think about it that way. For example, if I told you you had a cancer in your stomach and the only way to cure your cancer was to do a sleeve gastrectomy, you'd do it in a heartbeat and not think twice about it, right? There are lots of things we do as surgeons that are irreversible. That's not the issue. The two issues with sleeve that you've got to be comfortable with are the little tiny portion sizes and that profound change in your relationship with food. If you're comfortable with those things and you're pretty confident you're going to be comfortable with those things in pretty much an irreversible way, then sleeve gastrectomy is a very responsible thing for you to think about. If you're just in your gut not comfortable with those things, you in your mind imagine you would have to get used to that. You really want to think long and hard about having a sleeve gastrectomy. But if it is for you, I understand, and I think you're going to be very satisfied.